Okay, hello and good evening. I want to start by thanking you all for joining us today for our Stem Cell Community Lecture Series. My name is Lisa Flanagan. I'm one of the faculty here at the Stem Cell Center, and I am going to be subbing in for Eileen Anderson, who's our director. I'm going to give a little bit of an introduction to the Stem Cell Center, and then we're going to have two speakers tonight. I'm one of the speakers, and then our other speaker is Wenyu Yu, who is my colleague in neurology, who's a stroke neurologist. Okay, so we'll start with just the introduction to information about the center. And first, we'd like to thank Brian Cummings. He's our faculty member who organizes this series. So we appreciate his efforts in that area. And then I also want to give a shout out to Abby. She's the admin person here who gets us all organized and makes all this happen. And then lastly, UCI Media. Say hi to Will in the back. He's here to record everything and make sure it all runs smoothly. So we appreciate all their help to make sure that this works really well at all our community lectures. So I'm going to talk for a few slides about kind of how science happens and from the perspective of stem cell science, and how do you go from taking basic science findings and taking them into patient care. And so most of the treatments and therapies and things like that we get as clinical care started with basic science. So it started with somebody in a lab who had an idea and tried it out and found something, and then they had to kind of go through the steps to get it to the point where it could be applied to patients. And so it's really important then that we have places like the Stem Cell Center and groups of like the scientists that work here doing these kind of studies so that we can move them forward for patient care. So when you do that, there are several different steps that have to be taken. So it starts with that basic science discovery. Then you have to think about, okay, now I've been applying this to cells in a dish. It's a very small scale. I now want to apply it to a larger patient population. You have to think about scale up and manufacturing, and how do you turn this into a therapy? So that's part of what has to happen along the pipeline. And then once that occurs, you have to test it in humans. You have to make sure that whatever the therapy is going to be safe and effective, and you have to do that in a really rigorous way. So that's an important aspect of this as well. So if we look at what kind of an impact then this basic science research has, it's huge. And so you can even just look at these numbers. It gives you an idea of how many patents and licenses and new startup companies come out of this basic science research. And that's part of that aspect of figuring out the scale up and how you turn this thing into a therapy. All of that usually goes through companies in that type of a pipeline. For us at the center, we actually have several companies that have spun out from research that faculty are doing here that are moving forward with things that they're trying to take into clinical trials, so we're really excited about that. And another thing that we have here in the center that helps us to move things toward therapeutics is we have the Alpha Clinic. So that's funded by CIRM, which is the California Institute for Regenerative Medicine. And this is a way in which we can take these basic science discoveries, do initial clinical trials. These are called phase 1 clinical trials, and they're to test the safety of a particular therapeutic, and then move along into more final clinical trials to see whether the therapeutics are effective or not before they get taken into patients. And our director of the Alpha Clinic is Dr. Daniela Boda, and she's been extremely successful in terms of increasing the number of clinical trials that we have running through the Alpha Clinic here at UCI. So you can see how much growth there's been from 2019 through 2022. We also have critical partnerships with other entities in the area. So for example, the Long Beach Veterans Administration, Children's Hospital of Orange County, University of California, Riverside. So these enable us to kind of enlarge our network and take some of the things that we're finding here and apply them across various entities here in Southern California. Another thing that we're really excited about is we have a new GMP facility. So GMP stands for Good Manufacturing Practice. And again, this is part of that pathway of, okay, so I've got something that I think is going to be therapeutically useful, especially if it's a cell-based therapy. We have to make sure when we're preparing those cells for human clinical trials that they're prepared in the best way possible. There's no contamination. The cells are very pure, whatever needs to happen. And so we built this special facility here at UCI to do just that. So there's individual rooms for each batch of cells that has to be prepared for implantation into a patient. The individuals that work there dress in these hazmat suits like you see there to make sure that they don't introduce any contamination. But it's very important to the whole process of taking things towards clinical trials. And we're very excited. We have a new director, Roberta Marino, and so she's gotten this up and running, and we just had a grand opening at the end of May, so we're very excited for that. All right, so this brings me to our speakers. I mentioned I'm one. I'm now going to turn over my microphone to Nini. She is a graduate student in my lab. She's going to do the honor of introducing me, and then I'm going to talk, and then I will introduce Dr. Yu, and then he will talk. So I'm going to hand it over to Nini.
Okay. Thank you. Hi, everyone. I'm here to introduce Dr. Flanagan, who's my PI in my lab. So Dr. Lisa Flanagan is professor and vice chair for academic affairs in the Department of Neurology at the University of California, Irvine. And she has joint appointments in biomedical engineering and anatomy and neurobiology. Dr. Flanagan's research program combines expertise in neuroscience, cell biology, and engineering to explore neural stem cell function and maximize repair of the central nervous system after debilitating conditions such as stroke. Before joining UCI, Dr. Flanagan completed her PhD at UC San Diego and postdoctoral training at Harvard Medical School in Boston, Massachusetts. She received the National Science Foundation Career Award, serves on the editorial board for scientific reports, is a fellow for the Center for the Neurobiology of Learning and Memory, and has organized multiple international scientific conferences. And now I will pass back the mic to introduce Dr. Yu.
Thanks, Nini. Okay, so actually I'm going to do my talk and then I'll introduce Dr. Yu right before his talk. Okay, so yes, thank you all for coming, and I'm really excited to talk to you about some of the work that we're doing in our lab that has relevance for stroke. So sort of as Nini mentioned, I have a joint appointment in biomedical engineering, and one thing that I think is a little bit unique about our research program is we're bringing together multiple fields. And so a lot of times, we're trained as biologists, and so when we're trying to answer biological questions, we'll just use some technique that we know from biology. And what I've been finding in my lab is that by adding in techniques and ideas from other fields, in particular engineering, it really gives us a new way to answer some of these biological questions. And we've been finding that to be really fun. So first, let me tell you just a little bit about stem cells. So what I'm showing here on this schematic is pluripotent stem cells. So those are stem cells that can turn into any cell type in the body. And they occur during development and are part of what allows our entire body to form. But in my lab, we're particularly interested in neural stem cells. And these are cells that will form the central nervous system, so your brain and spinal cord. And part of why I'm so interested in these cells and why I think that they're so fascinating is that, during development, there's a stage where you have just a single layer of cells, okay? And that single layer of cells is going to divide and turn into other cell types and differentiate and form the incredible complexity of the human brain, right? So all these cells that are allowing us to hear the words that I'm saying, see the things that are on the slide, feel that you have kind of a itch on the back of your head, all of that is controlled by these cells that came from a single layer of cells. And I think that's just amazing that that can happen. So we're interested then in these cells not only for how they do that during development, but how we might be able to harness our understanding of those processes to apply to regenerative approaches for things like stroke. So if we think about how this occurs during development, I'm showing you a schematic now of the developing brain. And this region right next to this fluid-filled area, this is called a ventricle. This is actually the lateral ventricle. And where we see stem cells in this developing brain is right next to that fluid-filled area. So they have this nice lakefront property in this region that we call the ventricular zone, and that's the stem cell niche. So in that niche, you can find very undifferentiated neural stem cells. You can find more committed progenitors that have started to decide what path they're going to take in life. And you can eventually get the fully differentiated cells of the central nervous system, so neurons and astrocytes and oligodendrocytes. So the thing that I'm going to talk about today is relevant for stroke, and my colleague Dr. Yu is going to give us a lot more information about stroke, but there's a couple things that I wanted to point out from this schematic that are going to be important for what I'm going to talk about next. And basically, the point is that when you have a stroke, which is still a leading cause of death and long-term disability, and really a major public health concern, what happens, particularly in ischemic stroke, is you have a vessel that gets blocked off. So you can see that here in this vessel. So in this case, there's a plaque, there's a blood clot, and that's preventing any blood from going through that vessel. So what happens then in the brain is you block off this vessel, and then you have this whole region of the brain where the tissue basically dies off because all those neurons and astrocytes and oligodendrocytes and all those stem cells are no longer getting all those nutrients from the blood, right? They don't have oxygen, so they start to die off. So that's a big problem. So you might think, well, we talked about neural stem cells, and maybe they might have some regenerative properties. Could they be doing anything useful in the context of stroke? And it's interesting because you do actually have stem cells in your adult brain. And you can see in this schematic, this red line shows where they are, so they still are along their lakefront property, they're hanging out there. And when you have a stroke, there is a little bit of limited activation of that stem cell pool, but clearly it's not enough. It's not enough to really repair the damage from the injury. So we have to think about other approaches. What we've been thinking about in my lab is, okay, how are the stem cells interacting with other partners in the brain? And in particular, we're interested how the neural stem cells are interacting with endothelial cells. So endothelial cells are the cells that make up the vessels. So you can see them here kind of lining along the edge of the vessel. And so because those endothelial cells make vessels, because the vessels are disrupted in stroke, and because the neural stem cells are also there and have some regenerative properties, we want to try to understand the interaction of those two cell types with each other. Okay, so this is our basic question is, okay, how are the human neural stem cells impacting the human endothelial cells? And how are the human endothelial cells affecting the human neural stem cells? So it's this kind of bidirectional communication between these two types of cells. And actually, we're really excited to be part of the Stem Cell Center because it gives us a chance to look at this with human cells. And actually, we found that's really important. We've done some analysis where we've compared human cells to rodent cells, and there's big differences, at least in terms of some of the signaling molecules that we're looking at for this bidirectional communication between rodents and humans. So we think it's really, really important to do these studies with human cells. Okay, so we're going to look at the interaction between human neural stem cells and human endothelial cells. So how do we do that? So we do that by taking these two cell types, and we give them different colors. So for my talk today, the neural stem cells are going to be green, endothelial cells are going to be red. We mix them together and we put them in a three-dimensional scaffold, and we do that so that they have more sort of a three-dimensional way to interact with each other, which is much more like it would occur in the human brain. And that scaffold, we've done a couple of things to make the properties of that scaffold very much like brain tissue. So one thing is your brain's actually really, really soft. We don't actually touch brains very often, but if you were going to touch a brain, it's really, really soft. And so one thing that we had to think about was we want to make this scaffold really soft so it matches the brain properties. We also wanted to add in other types of proteins and things that we would find in that stem cell niche, that lakefront property, so we've done that. So we put them together in this three-dimensional scaffold. The endothelial cells will start to form vessels, and we can look at that interaction. So what we found when we did those kinds of experiments is that if we put neural stem cells into the scaffold with the endothelial cells, they formed much better vessels than if we had the endothelial cells by themselves. So this was pretty cool. Actually, this was kind of a surprising result when we did it. And so this was like, oh, so there really is this communication from the neural stem cells that's telling the endothelial cells to form vessels. So that brings me to my title of my talk. Okay, so how are they communicating, right? And so then, all right, what are the different ways that we communicate? If you think about how people communicate, back in the days, people didn't even have phones, right? They couldn't call each other. Then they got to the point where they could call each other on the phone, but you couldn't leave a message. Then you could leave a message, but it was on, this answering machine that I'm showing here from Panasonic, and you would get the message, you'd come back at the end of your day, and you'd look to see if you had any messages on your answering machine, right? So it was kind of, there's communication, right? But it's not a very complex mode of communication. Now, fast forward, and here we are today, and we've got, Instagram DMs, right? And so you want to contact somebody, you just drop into their DMs, and you can exchange all sorts of information. You can tell them something, they can get back to you right away. You can send them a video, they send you a picture, there's a couple of emojis. So it's a much more complex form of communication. So we wanted to try to understand, all right, how are the neural stem cells telling the endothelial cells to make vessels? And so we started thinking about, okay, what would be an analogous situation in terms of how cells communicate? And so I'm going to say that cell voicemail is kind of how we've thought about cell communication for a long time. And that would be, you have one cell, and it makes a protein, it sends that protein, and that's what's labeled as the ligand here, sends that protein out, that binds to a receptor on the target cell. Once it binds, there's some sort of a response in the target cell, okay? So it works. It's pretty simple, but you can definitely communicate that way. I'm going to argue that cell DM is more complicated, and this is exosomes or extracellular vesicle signaling. So what happens here is the cell, instead of just spitting out this one protein, it puts together these little packages, and these little packages are called exosomes. And in those little packages, you have all sorts of stuff. You've got membrane proteins, cytoplasmic proteins, lipids, and then RNA and DNA that can turn into new proteins in that target cell. And these cells will send out these little packages. It gets taken up by the receiving cell and has all sorts of changes in the receiving cell. So it's a much more complex form of communication that, frankly, we only discovered kind of recently. So we didn't even know it existed, all right? So that's what we were interested in. So we started to ask the question, okay, so are they communicating through DM? And I want to just pause for just a second and say, I should have said this earlier. A lot of the work that I'm going to talk about today is from some really talented grad students in the lab, particularly Brenda Gutierrez, who's an MD PhD student who's finished her PhD and is back now doing the rest of her med school, and then Nini, who very kindly introduced me. And then I also want to shout out Greer Cisneros, who was also in the lab for a year and worked on a lot of these projects. Okay, so how could we tell whether this is a way that the neural stem cells are communicating with the endothelial cells? So what they did was they said, okay, we're going to purify these exosomes, these little packages, from the neural stem cells, and we'll put them on the endothelial cells. And what we saw is, wow, we got more vessel formation. So that is a way that the neural stem cells can tell the endothelial cells to make more vessels. So because we're biologists and we're never happy with just one experiment, we always want to kind of, add something, then we want to take it away and see if the opposite things happen. We did an experiment. Okay, we did an experiment where we blocked the formation of the exosomes. Okay, so we can treat the neural stem cells with a drug. It prevents the exosomes from forming, and then we can say, okay, so now that we no longer have those little packages, do we still get an effect on vessel formation? And we don't. So what we see in our picture here is there's less vessel formation, and you can see that in the graph. See how this bar drops down compared to that one? That means that if we block the exosome formation, we don't have the little packages, they don't stimulate the vessel formation. So what do we want to think about next? Well, this is really cool, right? We have a mechanism now for how the neural stem cells are causing vessel formation, but if you think about vessels, you have to have the vessel itself, right? But you have to have fluid flow through the vessel or it's not really going to work, right? If you're just forming the tube but it's not open and allowing the blood flow through, we haven't really solved the problem. And we really wanted to see whether, okay, could this whole mechanism be useful for rebuilding these blood vessels in this ischemic area and then being able to deliver more blood and oxygen and help to rebuild the tissue. So Nini has been working on a project really recently. I'm showing some of her newest data where she's been looking at whether there's a hole through the vessel? Is there a tube that's open, which we call a lumen, that would allow flow through? And the answer is yes. So if we have the neural stem cells, we get this big increase in lumen formation, and if we block those packages, block the exosomes, it drops down. So these little packages are telling the cells to make vessels, and they have tubes that could carry flow. So the next thing that Nini wants to ask is, can we actually get fluid flow through those vessels? And now we're going back to the engineering, and we have a colleague, Chris Hughes, and also with Abraham Lee and Steve George. They created this really cool microfluidic device where you can put fluid through, and you can get vessels to form in a center chamber, and then you can put fluid through, and you can see the fluids coming in through this microfluidic channel, and then it courses through the vessels and comes out the other side. And so then these bottom images are from Nini, and you can see here's just when she first put the colored dye in, it starts to go in the vessels, and after 30 seconds, you can see it's going through all of the vessels in that inner chamber. So we're really excited about this because it gives us a very direct way to now see, okay, are these vessels going to carry fluid flow, which would be critical for regenerating the lost vessels after stroke. Okay, so the other thing that we're really excited about this is we think this could be a viable therapeutic for stroke one day. We're not there yet, and so, it's going to take some time, but the advantage is instead of having to think about neural stem cell transplantation for stroke, which is a little complicated, right? You have to, go into the brain and put them in. Something like an exosome is really cool because it can cross over into the brain. So you can just do an injection into the bloodstream, and then the exosomes in this schematic are these little orange guys. They will cross over, enter the brain tissue, and then could potentially help to repair those damaged vessels that we have in the damaged regions from stroke. So we're super enthusiastic about moving forward with this line of research to see if that's going to be a possibility. All right, how about the other side? We've talked all about how neural stem cells are affecting the endothelial cells. How are the endothelial cells affecting the neural stem cells? And this was a project that Brenda really worked hard on and got so much really interesting data, because what she found is that the endothelial cells are telling the neural stem cells to turn into an adult neural stem cell phenotype. And these adult neural stem cells, it's the ones that I mentioned before, they're in your adult brain. We don't know why they aren't fully responsive to injury, but we would like to know why they're not. And one way that we can know that and try to understand that is to study them. But we didn't have a source before of having these adult neural stem cells. But now we see, okay, well, the endothelial cells will turn them into these adult neural stem cells. Now we can understand more about their function. And so in terms of the communication here, what Brenda found was this was an even different form of communication. In this case, she had to have contact between the cells. So they had to physically touch each other. And when they do that, and she found that it was through this particular protein that was on the endothelial cell that's called a Notch ligand, another protein that's on the neural stem cell that's called the Notch receptor. And once they bind to each other, it starts this signaling cascade in the neural stem cells that tells it to turn into an adult neural stem cell phenotype. And so we were really lucky to get a collaboration with Mercedes Paredes' lab at UCSF, and we were able to look at some human tissue. And when we did staining, and this was some work that Nini helped with as well, we could see that we saw the contact between the neural stem cells and the endothelial cells in the tissue. So we've got the blood vessel shown here in this blue color, and then the green and the red are both showing the type B, the adult neural stem cell, and you can see how they're just reaching out and wrapping around in both these colors, wrapping around the blood vessel. So that was really nice for us to see too, because it means that that type of contact interaction is actually happening in the brain. All right, so in summary, we found that the neural stem cells are using their DM, using their exosomes to tell the endothelial cells to make new vessels, and then the endothelial cells are going back and telling the neural stem cells through a contact mechanism to turn into this adult neural stem cell phenotype. So again, this is the kind of thing we do, kind of combining engineering and neuroscience and stem cell biology to better understand the brain. And then these are the people in the lab, and I think I've already talked about Brenda and Nini and Greer, but I want to thank them so much for all their hard work on this project. All right, so maybe I'll just take a couple questions, and I'm going to introduce Dr. Yu.
So how long does it take after an artery is blocked for ischemia to happen?
That's a really good question. I'm going to turn that one over to Dr. Yu.
Thank you.
Can you repeat your question?
Yes. How long does it take after an artery is blocked for ischemia in the brain to happen?
That's an excellent question. So each individual is a little bit different. Generally speaking, it can be a couple hours to even 24 hours, depend on your blood supply to different part of the brain, and also depend on the collateral circulation. We all have like a very, like a huge, we call it small vasculature that provide the blood supply from different major artery to different part of the brain. So I will mention that in my talk to answer your question.
Thank you.
Okay, so maybe this is a good opportunity then for me to introduce Dr. Yu, and we'll move into his part of the talk. Okay, so Dr. Wenyu Yu is professor and vice chair for hospital affairs in the Department of Neurology at UCI. He's also the director of UCI's Comprehensive Stroke and Cerebrovascular Center. He received his MD from Jiangxi Medical College in China and his PhD from McGill in Montreal. He did a postdoctoral fellowship at Harvard Medical School in Boston, and actually, just when I was looking through your record, I realized we overlapped there, although we didn't know each other at the time, but we were there for a couple of years where we overlapped. He completed residency in neurology at the University of Missouri and a fellowship in neurocritical care at UCSF. So UCI successfully recruited Dr. Yu here in 2015, and since then he's been really instrumental in building up our amazing stroke center, establishing a vascular neurology fellowship, and creating a vibrant neuro ICU where physicians are dealing with some of the most challenging cases in neurology. He has an impressive record of publications, invited lectures, clinical trials, and he's really continuing to push forward the frontiers of patient care for those dealing with stroke. So I'll turn it over.
Thank you so much for your kind introduction. I was fascinated with your next lecture. I think the cell type you work on will have great potential for stroke recovery. I will explain why from my lecture. While I listened to your talk, I was thinking, quit my daytime job, work for you. So let me see. So there are two types of stroke. Dr. Flanagan already mentioned it. So one type is ischemic stroke due to like arterial occlusion, lack of blood flow to part of the brain. Second type are hemorrhagic stroke, either from a ruptured artery or from ruptured aneurysm. So both can be devastating. You know, the picture showed, one's arterial occlusion, the other is rupture. And, those are two devastating conditions. In 2019, that's the most recent data we can have in the United States, more than 7 million people had a stroke in a single year. So sometimes every, a few minutes, somebody, had a stroke. So it's the second leading cause of death worldwide. And third leading cause of long-term disability. Can you imagine after stroke, a patient cannot speak or cannot speak normally, cannot move one side of the body or walking. So it's very devastating. And luckily, we can do a lot for patients. Let's just show volume. How many stroke patients wait that meet our new slide? So the way back to 2001, so the number gradually increased, maybe it started to peak around the 2014 victim partly. The hospitals always super busy, saturated, the ED always too busy. We call ambulance to we go to other hospital if we don't have a bed at the UCI Medical Center. So luckily we will have a new hospital nearby here on campus. So the common symptoms of acute stroke are following. It's always sudden because this accident, artery, accidentally closed or ruptured. So it's always sudden symptom. So suddenly loss of balance, loss of vision in one eye or both eyes, loss of, weakness, sudden weakness in the arm, face or leg, can be all of them. And the sudden slurred speech or unable to speak. So anyone had any those kind of symptom, it's time to call 911. So we call it be fast. That's the most important word to remember. Because the time is brain, one of the member here asked, how long the brain can tolerate the ischemia. And before we get to that, let's mention a few common risk factors. By far the most common and the major risk factor is hypertension. So uncontrolled blood pressure. It can damage the endothelial cell and also potentially, damage a stem cell in the brain. The second one is poor diet, and either unhealthy diet or either too much, either way, it can do harm. And the high cholesterol, especially high LDL. And with those two, I just want to emphasize how important it is medical research or stem cell research. For example, everybody know the popular saying, take aspirin once a day to keep a doctor away, because aspirin can reduce risk of stroke by 20% if your patient has some of those risk factors and the history of stroke. The second medication is Lipitor. So you take a Lipitor a day, keep a cardiology away, and also keep a stroke doctor away. Because the high LDL, we call the high low-density lipoprotein, is a major risk factor for atherosclerosis in the heart, also in the brain. So certainly like obesity, physical inactivity are also risk factors, cardiac disease. Some of those are all secondary to that high blood pressure, high cholesterol, and inactivity. And the smoking, certainly methamphetamine use, cocaine use are risk factor. The last one, not much we can do, like advanced age or some family history. But luckily, we still have a way to reduce risk of stroke or help a patient to recover better after stroke. So the good news is, like I mentioned, aspirin, Lipitor, and everything else working together can prevent 80 to 90% of stroke. Just pay a little bit of attention, then we don't need to worry about stroke. So luckily, in modern days, there are a lot of research, high tech, help us to diagnose stroke so quickly. I just show you one picture. Patient showed up in ED. We can do a very quick neurologic examination within maybe 5 minutes to know exactly what's the issue. Then get a CT, like a CT scan, CT angiogram, or CT perfusion study. Even on our cellular phone, even I'm on call at home midnight, so I hear, alarm, patient had a stroke in hospital. I open my phone. I instantly can see the CT scan of the brain and the artery and also perfusion. So is that area had a, loss of blood flow, like the color-coded, that the perfusion scan in the bottom panel showed the red color on the, left side. That area is at risk. So if you see that, it gave us up to 24 hours to save that brain. So each individual is different. So it depends on the cause of a stroke. So, like I said, if patient has good collateral circulation, multiple vessels provide blood supply to that region, they can last longer. If patients do not have collateral circulation, then maybe 4-6 hours. But still, luckily, most part of the brain can survive a couple of hours. So, because research has worked so hard in the last 50 years, they developed 2 very effective treatments for acute ischemic stroke. The first one is medication we call the clotbuster, the TPA or TNK. So this medication has to be used like within 4.5 hours. So after 4.5 hours, generally speaking, it doesn't work. And it also increases risk of bleeding, because when you kind of open the artery too late, it potentially can cause harm, because the endothelial cell was damaged. Then blood can leaking out, cause additional damage. So that's why I said the endothelial cell is one of the most important cells inside of the brain. And the second type of treatment that's most significant advanced in the last 20 years. So now the surgeons, we call the neurointerventionists, they can put a catheter from the gloving all the way go to the brain, past that blood clot, release, we call the stent, try to capture the blood clot and remove it from the leg. So that can be done up to 24 hours. Occasionally it can be even longer, depending on individual cause of stroke. So it's really important. Any patient, if you know anyone who had a stroke-like symptom, call 911 right away. Go to hospital earlier, get a better chance of treatment. So this, table showed why, early treatment can have better recovery. So this study based on the pooled data. For example, if patient get this clot buster called TPA or TNK treatment, if they get a treatment within 19 minutes of symptom onset, you treat every 4.5 patient, one additional patient can recover to normal. That's really good chance. Recover to normal, that's super effective. If you delay 90 minutes, then if you treat 91 to 180 minutes, you have double the number of patients to get one patient benefit from the treatment and recover to normal function. Then if you continue to delay, like more than 3 hours to 4.5 hours, you still get a small benefit. Then you have to treat like more than 10 patients to help one patient to recover to normal. So early treatment is the key. So call 911, and the comprehensive stroke center know how to make a decision to provide a treatment and save life and improve recovery. This diagram shows how likely people can recover after big stroke. For example, from the occlusion of one of the major artery, go up to the brain, can be we call the carotid artery, or the artery in the back called the basilar artery. If one of the major arteries is occluded, you give this medication, a clot buster, it's less effective because the blood clot can come from the heart. It may be already really formed. You really cannot lyse it. It's not effective anymore. So the diagram on the right side showed if patient had a big stroke, the medication will help 2 patients, the top, the green color, the blue color, sorry. I'm kind of, sometimes in my Chinglish, green, blue, I say confused. I'm a little bit confused on this. But anyway, so it can help 2 patients recover completely. Still, 22% chance have a full recovery from medication alone. Then additional 11 patients can improve, but not fully recovered from this type of treatment. Then most patients no benefit from medication alone. And one patient may have a harm from the medication. For example, you gave a little bit too late. The endothelial cell is already damaged. Blood leaking out. It causes more trouble. You get a non-hemorrhagic stroke in addition to ischemic stroke. The second type of treatment I mentioned called clot removal endovascularly. You go in directly all the way to the artery, try to pull that blood clot out to reperfuse the brain tissue to protect the stem cell, to protect the endothelial cell. Then you can see 30 patients on the left panel, 30% of the patient can recover to normal function after 3 months. That's really impressive. Major stroke, imagine you cannot talk, you cannot move one side of the body, or you almost comatose, open eye, you don't know nothing. With that treatment, 30% you recover to almost normal after 3 months. Then additional 25 patients have some improvement. So I have to mention this, the fascinating part. So why stem cell, endothelial cell are so important. Even you still have a significant disability or deficit after 3 months, maybe the stem cell, endothelial cell, they will continue to grow, regenerate. So actually, after 1 year, half of those patients can continue to recover to almost functional, get around, with minimal support. So anyway, so then the best treatment sometimes do not help approximately, 40% patient because too late. So there's always, massive damage to the, brain tissue. Most of those, for example, wake-up stroke. Patient went to sleep, maybe had a stroke, midnight. The next day, nobody knows until, by noontime, somebody trying to say, why I didn't get up yet, then kind of a little bit too late. So one patient get a complication and may die from it, afterwards. Another patient had became worse because complication, bleeding, mostly because of endothelial cell damage and, bleeding, we call it reperfusion hemorrhage. So those are the outcome. This also slide show how important it is stroke recovery. Like the research done by Dr. Flanagan eventually will show how the stem cell and the endothelial cell can regrow and help patient to recover, help to build the network again in part of the brain tissue. And this just briefly show in case patient had a hemorrhagic type of stroke, what will be the new treatment? The two type of treatment. So it depends if the artery rupture, that they can go in with this minimally invasive hematoma evacuation treatment to reduce the mass effects. After you remove the bigger chunk of blood, then the nearby maybe stem cell and the endothelial cell can become healthy and grow again. And the second type of treatment is when patient has a ruptured aneurysm, that can be treated surgically or endovascularly by either coiling or clipping. I don't know, some of you guys may know that President Joe Biden had 3 aneurysms in 1988. So he had a surgical treatment for 3 aneurysms. So with that clipping, they put those clip at the neck of aneurysm to help him recover and to prevent additional hemorrhage. So it's a really effective treatment. And what is the chance of recovery if patient get a hemorrhagic stroke? There's a diagram, let me show some of this. So hemorrhage can be more devastating because it's irreversible. The damage is done right away. Ischemic stroke, I mentioned, is still 4 hours, even 24-hour time. You can save that as long as you can send the blood back to perfuse the brain. Then patient can recover, even recover completely. With the big hemorrhage, like show that white color, within the brain, it causes the damage to that area right away. So that area is done. So that's why those are more deadly. So if a patient had a big bleeding, the chance to recover is much lower. So maybe 6 patients can recover to good function. And, by 30 days, 43 patients will have died at least, even at a good, comprehensive stroke center. The 51 patients will have a severe disability. But we do have some good news. With additional research, if we can help those patients currently, even those patients, 50% still can recover at 12 months. That means from 30 days to 12 months. During that time period, the brain still recover, build up some communication, new link, send email, voicemail to connect each other. It's fascinating. When those patients lying on bed cannot do nothing, 12 months later, they come here walking, a little bit of weakness, they hello, and then you be surprised, we see those all the time. It's a fascinating, very rewarding experience. So this table just shows the UCI Medical Center stroke service has been actively doing clinical trial to help patients to recover or to prevent additional stroke. So the first trial is one of our faculty member, Dr. Ando. He's doing fascinating research. He used this brain-computer interface, technology, try to help patients to recover with leg, foot weakness. To say if somehow brain can communicate with the leg better with the computer system. It's fascinating. In the last 4 or 5 years, he enrolled 70 patients for this trial. It's impressive. Then the other trial we call that, so either should we use anticoagulation or Lipitor or some other, we call the recombinant factors, 7A, for different type of, stroke treatment, like a hemorrhagic stroke treatment. And we also have additional trial with 3 new medication or combination to prevent additional ischemic stroke, I think, because of time strain. I don't want to go to too specific details here. And certainly, some try even, do sleep smart, because sometimes people get a stroke because they cannot sleep very well, partly sleep apnea, they lack the oxygen inside the brain or retain of, carbon dioxide too much inside the brain that increase risk of stroke. So we have sleep smart. Then we also have interventional treatment, like we call that, carotid revascularization to prevent, stroke. And we completed a few trials already. So those are all I want to share with all of you. So anyway, stroke is a medical and neurological emergency. It's very common, but the good news is most of stroke are preventable. So we can, just eat healthy, exercises, drink water, don't get dehydrated. And there's always a treatment option. Like I said, if you show up, the patient show up in the emergency room as soon as possible, the potential treatment window actually is good for ischemic stroke. With the medication, must be show up for 4.5 hours. With endovascularist, can up to 24 hours, even longer window for some patient. And we can treat hemorrhage with minimal invasive surgery. We can treat ruptured aneurysm. And still, after 30 days or 3 months, almost half of the patient after big stroke is still severely disabled. But the good news, the type of research, Dr. Flanagan and the other scientists are working on, potentially will improve the chance of recovery much better, because the brain do have ability, to produce new link, new communication to recover. It's amazing. We see how patients recover. I have a lot of patients, especially at a young age, they get a stroke. After a couple of years, they're back to normal. You cannot tell they ever had a stroke. So that's a good news. Thank you so much.
So I think, one of the things we really want you to remember and tell your family members is if you have any signs of a stroke, just remember that be fast, okay? So balance, eyes, face, arm, speech, and then the T is time, because you want to get to someplace like the UCI Medical Center as quickly as possible. You don't want to say, oh, I'm feeling kind of strange, I think I'll go take a nap. No. You want to call 911, get to the medical center. And one thing that I think is really impressive about what Dr. Yu has been doing with his team is they've really got it down to a science. So if you come in that emergency room door and you're showing symptoms, they're going to get you imaged really quickly, and then we're going to get their treatment started as rapidly as possible. And that's something they actively work on day in and day out to get that time as short as possible to make sure that they get as many people treated as possible. So anyway, I think it's really impressive what they're doing there. All right, so we can take questions for either one of us from the audience.
You're doing with your team, the kind of regenerative medicine treatments. In theory, best case scenario, would you be doing that at the time of stroke, or is this something that could be applied later and you can expect recovery for those people? Recovery hasn't been possible.
That's a really good question. And I think that for me is part of why I found it so interesting to work on something like stroke, because because with stroke, and Dr. Yu kind of mentioned this in his presentation, you have somebody that's gone through a stroke and then they have a period of disability, but for some people, they can have some recovery for 3 months or so after their stroke. So what I think is an advantage about thinking about like an exosome therapy or something like that, you could, someone could have a stroke, you can wait for 3 months, see how much recovery they have, right? And then you could try, okay, they've plateaued, they still have a lot of disability, then you could try something like an exosome therapy, and you can see whether it kind of goes up from there. Now, that's something that we would need to test in a bunch of studies ahead of time, and we would check, like, okay, is it better if we give exosomes, within 24 hours or 48 hours or a week after the stroke, or is it better after 3 months? Could it still be effective after a year? Those are all the kinds of studies that we would have to design to test that. But what I think is so interesting about stroke is the fact that you can sort of see how much recovery there is, and then can you push it beyond that?
Hi, thanks for presentation. My question is, based on your research, what are the reasons that particular cells have preference for serving as communication media, and then specific manner that they also communicate?
Yeah, that's a really good question. So in terms of why there's specific cells, we think it's because of the way that they have sort of learned to interact with each other, even sort of throughout development. So I mentioned before that you have that single layer of cells and it starts to turn into the brain. At a very early stage, they're already interacting with the endothelial cells because they have to tell the vessels to start to grow into the brain. So they've had that communication kind of back and forth with each other from just the earliest stages of trying to put the brain together. So I think that that's part of it. And one thing that Nini's been actively testing is, are all the neural stem cells the same, right? So will any old neural stem cell do this? And so far she's finding, yeah, pretty much like everyone that we've tested has been very effective at doing this. So that was the first part of your question. And then remind me what the second part was.
And the second one,
Oh, it's what is the key?
the mechanism, that the specific mechanism for each of the respective cells.
Right.
In essence, they choose to communicate. One is by, let's say, voicemail, and the other
Right,
one is
right.
by smoke.
Right.
But they prefer certain, at least that's my impression.
Yes,
they
yeah.
prefer certain way.
Right.
Method.
So why are they choosing those particular ways? So I think that part of it will have to do again with what are they doing under normal conditions. So if we think about the neural stem cells and secreting the exosomes, so kind of sending the DM to try to encourage vessel formation, we think it might be related to early development. The endothelial cells aren't right next to the neural stem cells yet, so they have to send a signal that can kind of diffuse out and get to them. Whereas later on, when the brain already has plenty of vessels, but it needs to tell the neural stem cells to become this more adult phenotype, they're right there and they can be in contact with each other. That's our best guess so far. Actually, frankly, I don't have a great answer for the contact one. I'm not really sure why yet. I think that's something we still have to figure out. Other questions?
I was wondering, in terms of the population of people who had a TIA, had one, what do you see as a percentage of people who then go on and have a second or a third one, perhaps?
It's a great question. So we have a so-called ABCD score, like a risk stratification system. So TIA depends on the symptom first. The symptom only lasts for a couple minutes, then the risk get another TIA or stroke maybe lower. If a symptom only a little bit numbness, tingling, so it's a low risk. But the TIA symptom, if involve your speech dysfunction, you cannot speak for more than an hour. You cannot move arm, leg for more than an hour. Then the risk of getting another one is much higher. Then the other risk factor. Do you have history of hypertension that the poorly controlled diabetes and age is another factor. So based on this risk factor, we decide how aggressive we start aspirin or other additional antiplatelet medication, or give you high-dose Lipitor and cardiac monitoring, more extensive workup. So depend on the symptom and the duration, as well as risk factor to make a determination.
Thanks for the talks. I had a question that came up at home, which was that when you're thinking about high blood pressure, and I was curious what you think about this. Do you worry more about the top number, the systolic, or do you worry more about the bottom number, the diastolic?
Yeah.
And for stroke in particular, does one of those numbers more important than the other?
That's a great question. You know, this is really scientific. So, generally speaking, for hemorrhagic stroke, the higher number certainly is risky. You know, if blood pressure, you know, SBP will go, systolic blood pressure go to 200. 200 almost a threshold, more likely to have a bleeding, hemorrhage, rupture. You know, like a flap. You know, too much blood go to the brain cause rupture. And the diastolic BP more related with we call the mean arterial pressure. So certainly went too high. If both went too high, they are also, you know, major risk factor. And after stroke, so certainly your diastolic BP blood pressure should not be too low because mean blood pressure is more related with brain perfusion. So actually, for ischemic stroke, so you less worry about, the diastolic is high because you want the mean arterial blood pressure high to provide perfusion to brain tissue. So we're more worried about the diastolic, systolic, the higher one. Generally speaking, we always target that, but we also want the lower one to be normal.
I guess I have a question for both of you. First, the question from medical standpoint or clinical is the difference in types of strokes present different consequences for a number of people who can recover. And then speculative question, which is more probably to you, is are there any preventive possible treatments that can be used? Just for example, like you use aspirin, something similar, whether we have some sort of mechanism that will send signal to stem cells, for example, in case of internal hemorrhage, to mimic the air, for example, to oxygen cause the artery, the rupture to clot. So my question is,
Yeah. So
severity.
Yeah, so severity certainly is numerous factors. So that's depends on which type of stroke. For ischemic stroke, we call the blood supply is the most important. Actually, you want the blood pressure a little bit high. So if BP blood pressure is low, so you stop your home blood pressure medication, give IV fluid, give more fluid to make blood pressure a little bit higher to provide perfusion to reduce damage. And if a patient had a hemorrhagic, stroke, bleeding, so you want to lower blood pressure as soon as possible. So that also times the brain. So we start the medication in the emergency room right away if blood pressure too high, especially if a CT already showed the hemorrhage. So those are maybe most effective. Then they get to a little bit more complicated. There's a different type of medication can be used. For example, the benefit is still, debatable. We do a lot of research on those clinical trials. So for example, if it's bleeding, we use medication to cause blood clotting to prevent, leaking, additional leaking. And certainly additional agent were tried to whatever can, stop, that mass effect. We gave a medication called mannitol or hypertonic saline. Hypertonic saline is almost like ocean water. They have 3% sodium chloride. When you gave this to patients quickly, it poured the water out of brain tissue to reduce the pressure near the hematoma, so that can prevent the additional damage. So there's a number of things we can do. If a patient needs, we call the ventilator support, then we can blow out more carbon dioxide, because that can cause artery dilatation and the trouble for patients. So So anyway, so it's a number of things we do. That's why we have an intensive care unit. We look at all the number, optimize everything to make sure patient get the best chance to recover and do better.
Yeah, and thank you for the.
Stem cells, now question.
Yeah. Yeah, thank you. Yeah, no, I think that's really interesting to think about it in terms of a preventative. And honestly, I don't know if we've really considered it that way, but if we can figure out what sort of stimuli or signals we could give to the neural stem cells to say, okay, really we need lots of those exosomes right now. We need lots of signaling to go to the endothelial cells because they're in trouble, right? That would be pretty cool because then that could be, you know, coming back to the question earlier, when might we apply this as a therapy? If we knew that we could really stimulate production, that could be something that could happen in, you know, pretty early on in the course of the stroke. I don't know, you know, maybe if you have somebody who's had multiple TIAs or something like that, and that might be a candidate population for doing some sort of a preventative. But yeah, that's an interesting line of research that would be pretty cool to follow up on.
Someone you now have a subject.
Right. Good. Let's add it to the list, Nini. Other questions?
A couple of questions. One, on the, everybody's different with different genetics, so you're studying the stem cell and the formation. How does different genetics impact that? Is that something you're studying? Is something, some people good at growing vascular in their brains and others not so good? And the second one is, once they're formed into the neural stem cells, what does it take for them to continue to develop into full brain cells, all the other varieties?
Okay, so the first question was about the genetics, and that's a really good one. And one that, yeah, that's another area where we definitely will need to do more research. I can say that we have probably looked at 6 or 7 genetically distinct batches of neural stem cells, and they're all having this beneficial effect on the vessel formation. But that is something that we're kind of screening through and looking at. And one thing that has been a really important area of research in the stem cell community that is something that we would want to apply to this is, you know, are there gender differences, right? You know, if they're male cells or female cells, is there any difference there? How about if it's, you know, one gender or the other for the neural stem cells versus the endothelial cells? So that's something we have to think about. There's also a push to look at cells that come from, you know, diverse races and populations, and that's something that we'll need to incorporate into our research moving forward. I'm going to answer your second question, then I'm going to hand it over to Dr. Yu, because I'm curious what he would say about genetics in terms of the stroke population that he serves. But the second part of your question was, okay, so then the neural stem cells, how do we have them move forward into differentiating into the, you know, the mature types of the central nervous system cells, neurons and astrocytes and oligodendrocytes? And that, there's a lot of protocols that researchers are finding that will help to sort of push that differentiation. Just in general, if we take away the signals that tell the neural stem cells to keep dividing, they'll spontaneously differentiate and they'll form all those different cell types. So what a lot of research is going into is how do we push it more towards neurons or more towards astrocytes or more towards oligodendrocytes. In the context of stroke, frankly, you're losing all of those cell types. Probably the ones we think about replacing the most are neurons because they don't replace themselves, whereas astrocytes can continue to divide and replace themselves. So that's definitely kind of a target population. So I'm going to take the genetics question over to Dr. Yu.
Oh, I have
that's right.
Yeah, that's an excellent question. So stroke risk factor, you know, 2 components is acquired. You know, you develop hypertension, hyperlipidemia. The other is, you know, family history, hereditary. Hereditary usually is a few type of gene mutation that cause the vessel wall abnormality. So either they can rupture easily, we call it dissection, or slowly, progressively develop a stenosis that occlude the vessel. So some we even don't know. I mean, we know a few type of, you know, mutation that can increase risk of stroke. There are some diseases, for example, in Japan, Asia, it's Moyamoya disease. So the big artery slowly closed because the endothelial cell and the vessel wall damage. And so this actually, is a fascinating area of medical research. And the second type of, genetic factor, I think maybe more fascinating for stem cell and any kind of basic research. I call it, you can identify the motivation center. Stroke recovery also related with motivation, because the relearning process, the brain certainly has a plasticity. They can manage to learn. For example, I never use left hand to write. If I practice for 1 year, I can do okay with my left hand. But some patients recover more quickly than others because they're more motivated. But we don't know why. Why some people are more motivated, other strokes, I don't care. I don't want to move. I don't want to do anything. So that maybe is a fascinating area for future research. Need a motivation. It's a practice. Anything we do need a lot of practice. So the brain has that plasticity and the connection. You just need to rebuild up. So I think I have a slide. Those are just tiny pieces of brain. They have so many network. Like if this one area was damaged, how to, reconnect certain area. That's the key. So we don't know too much yet.
Thank you. So was wondering what types of studies there are on how the consumption of alcohol affects strokes. I know probably a lot's not good, but.
Yeah, for stroke, certainly it's not a good, I know there's a different way to describe it. Certainly too much is no good, everybody knows. It damages the liver, it, weak the vessel, make the vessel weak. For example, I mentioned this hemorrhagic type of stroke. Then you form aneurysm. It's almost like a blow tie. If the aneurysm rupture, blood leaking out. So more alcohol is clearly associated with that. More alcohol also causes endothelial cell damage. We call it a condition we describe small vessel disease. So all the tiny vessels damaged because endothelial cell damaged by alcohol. And eventually people have unsteady gait, forgetful, and stroke. It's very common with increased age if you drink too much alcohol at a young age. In addition, alcohol also irritates your heart. Make it stressful sometimes. If you drink too much, you have a tachycardia, you feel palpitation. That gradually going on, there's one study that showed that every additional glass of alcohol increases risk of a condition called atrial fibrillation. So irregular heartbeat, that is a major risk of stroke. Certainly, minimize alcohol intake. Now, occasionally, small amount. Me, I don't drink more than 10 cc a week.
Dr. Yu, the use of AI in assessing patients who are coming into the ED, is that for everyone now? Is that something you do routinely? And what effect has that had since you started doing it?
That's an excellent question. So selfishly speaking, actually it gave us great benefit. Just to explain to you all the days. If 1 a.m. I get a call by my resident that we have a stroke in the ED, I have to wake up, go to the computer, log into we call the electronic medical record, and sitting there, wait for the CT scan is done, CT angiogram is done, then the technician will push the image or upload the image into the system. So I often midnight sitting there half hour, wait for the picture to show up. But now, as soon as the study is done, AI processes the image. I can see it right away on my cell phone, so I don't need to get up at all. Can you imagine the improvement in the workflow and the productivity? So make our life is really easy. And second, so AI, the specificity and the sensitivity, it's not perfect yet, I have to say that. We assist the 2 type of AI tool. The first one we call it rapid AI. It's, I have to say they had one problem, overly sensitive. They over-report, overestimate stuff. So then we have to be careful. Don't send the patient for aggressive treatment when they don't need. So we switch to the second type. The second type of the underestimate. I mean, it can be risky if we don't pay attention. Because, for example, most of those technology at this point give us a sensitivity or specificity 80 to 90%. So certainly we feel good. AI cannot replace us yet, at least. Because that 20% can be a big mistake. If we entirely depend on AI to make a decision, then 20% of patients will be mistreated or not get a treatment. So that's the current situation with the AI tools.
And how has that improved the treatment for patients?
Yeah, so decision time. So like I mentioned, in the past, I have to wait half hour to even see the image because I have to make a decision based on examination and the image because I can show the picture. So entirely based on the symptom or examination, I cannot tell with certainty it's an ischemic stroke or hemorrhagic stroke. So at least, a lot of patients, you have no clue, like I said, it can be both, yeah. So that improved, instead of wait 20 minutes, now you can tell right away, in 1 or 2 minutes. So you will reduce the damage of brain tissue. This saying, actually a word coined by Jeff Saver at UCLA. He said that every minute count. If you treat the patient a minute early, you can save a couple million neurons. I show the picture. How many neurons is that in a tiny, tiny piece? You get millions of neurons. So if you can make a decision 30 minutes earlier, so definitely will help the patient tremendously.
I actually want to follow up on her question. I'm wondering if at UCI, have there been any studies that compare how quickly people have gotten treated before AI, like you said, where you had to wait, half an hour for the images to show up versus now after AI. Has anybody done that comparison?
We had a paper, published a study for this big stroke. For minor stroke, maybe you cannot change it too much. For example, minor stroke patient, regardless of how you treat, at 3 months, almost everybody recover. So it's very difficult to identify the benefit. Then you need a huge sample size. Then each patient is different. So it's very difficult. But the patient with a major stroke, then there's other issue, in play. For example, when patient has a severe stroke, in order to do any surgery procedure, they need to have a tube in the air pipe to get oxygen. So to do all of those procedures cause significant delay. That's actually more component we need to work on. We tried to work on this for a while. So because sometimes big stroke occur midnight and weekend. So now all the delays, you have to call a physician and the technologist from home to do operation. So that delay is minimum 30 minutes. And then you have to put the tube in. You have like a respiratory therapist, everybody to transport the patient. Now that component, it's a major compounding factor to analyze the benefit of AI. So at this point, still questionable overall benefit if a patient needs a major surgery, because the other delay is still significant.
And are those two different types of AIs that you talked about?
Yeah.
Oversensitive and the under.
Yeah.
Are those both developed by Dan Chow?
No. This is all developed by different companies. Those are commercial. I think maybe Peter Chang may had a little bit role in one of this Vision AI, but I think those are all developed by independent company, not our own in-house product.
I just had a quick question. I guess as a follow-up for Dr. Yu. I know you're talking about the delay time in terms of getting care, the correct kind of care to the patients. And I know in several health systems like UCLA and I believe another one on the East Coast are starting to roll out mobile CT scanners. And it's quite incredible to see like a CT scanner loaded into ambulance showing up at a patient's house. Do you know if these are, I guess, the efficacy of these units? Are they useful out in the field? Is it possible to fully treat a patient, I guess, using such a mobile stroke center?
Yeah, I mean, that's an excellent question. So certainly stroke is one of the neurological emergency when patient had a symptom. So it can be anything, you know, like if somebody call ambulance on the street, you know, some patient can be just had too much alcohol, became unresponsive. So there are a lot of compounding factors. So overall, based on some study, so mobile stroke unit, that means ambulance with a CT, with a lab in the system, that indeed reduce the treatment time. So this provides benefit. However, it increased the cost through the roof. So how many ambulances the university have to run to save people's life? And how many people you have to hire? Because ambulance, do you want to have that ambulance 24/7? So single ambulance, you need to hire maybe 3 drivers. If you have a CT, then you need a technician. You need to draw blood to do tests, then you need to have a lab person. So most facilities, so I actually work with all those institute friends very well, like Cleveland Clinic, UT Houston had this mobile CT unit first, but then eventually the cost is too high. And they want a physician in the ambulance to make a decision. Then how many physicians you have to hire just to cover one ambulance? Nobody can work 24 hours, 7 days a week continuously. So that's the limitation.
Do we use those mobile CT?
We don't have, the cost itself is close to a couple $1 million. Even the folks discuss, even a company give you a free mobile unit. So how many physicians you have to hire? And how many drivers and the technician, and also this regulation, EMS regulation. So not any hospital can just send the ambulance out to compete with EMS.
We do have one in the ED.
No, we don't have our ED. No, we don't have a mobile stroke unit. I don't know if you mentioned, because initially you said that mobile CT. That's a different concept. That's just a portable CT scan. So you can move the CT scan anywhere. So we do have a portable MRI. Those are just, a simple piece of machine with much less specificity. The quality is still not very good, compared with standard stationary CT or MRI. Those are portable machine. That's different from mobile stroke unit, what you mentioned. Mobile stroke unit is almost a mini hospital in an ambulance. That's very costly. So generally speaking, it's not easy to implement. In Europe, they do a little bit better because they have centralized the hospital system. For example, some Europe city, the entire city, only 2 hospitals take care of stroke patients. So it's a little bit easier. I just share with you, Orange County itself have 28 hospitals. The ambulance take a stroke patient or questionable stroke patient to 9 hospitals, different 9 hospitals. So you just get through all those regulations. It's not easy here also.
Thank you. This has been very informative. Just a question, do you have any idea of how often or what the frequency is of people that have perhaps a bypass surgery and then have a stroke after recovering from the bypass surgery?
Yeah, that's a great question. So certainly bypass surgery in modern days, can be done really safely. However, there's always high-risk patient. Because bypass, you have to, almost stop a heart, bypass. And then also depend on the atherosclerosis. If your artery had a lot of plaque, that any, manipulation movement can cause, kind of dislodge or distal embolization. So overall, I think the risk is much lower in modern days because every patient that get a pre-surgical evaluation, clearance. So they optimize the medication, try to minimize the risk, but it still happens because the cardiac surgery. So the risk of complication then depend on each institute. We call that. So those are always true. So major medical center has more expertise, subspecialty support, they evaluate risk more comprehensively and know how to take care of poly-procedure care. That is, 24 hours, for example, after operation, how soon to take a tube out, can check on patient, and so forth. So generally speaking, we call that comprehensive academic center. The risk is much lower, but there are some high-risk patients that is always a possibility.
Okay, well, thank you all for coming out and sharing your Tuesday evening with us. We really appreciate seeing you here. Thank you.
Thank you.